Hi, welcome to EDSC 541. This is week 6, and this week we're going to be talking about eating disorders and also neurological disorders in childhood development. So with the eating disorders, we're talking about the most common eating disorders are anorexia, nervosa, and bulimia. Those are central to what's central to both of those disorders is intense and pathological fear of becoming overweight and fat, and the pursuit of thickness that is relentless and sometimes also deadly. Characteristics of anorexia nervosa is fear of weight gain and refusal to maintain normal weight. There are types, the restrictive type and the binge eating purge type. I have a video that I will apply a link for you to take a look at someone who is suffering from anorexia. Bulimia, the characteristics are frequent episodes of binge eating, lack of control over eating, recurrent in inappropriate behavior. So with bulimia, you restrict your eating and is motivated by a desire to be thin. Then you binge eat and restricted foods. Then you vomit excessively, exercise too much, or use of laxatives, and then you repeat. So, and that's the cycle for bulimia. Binge eating disorder, that's another one. And characteristics of a binge eater is frequent episodes of binge eating, typically overweight or obese, and no contemporary weight loss behaviors. So usually the three, when you compare them over time, anorexia is restricting marketably low. The binging and purging for anorexia is low. And bulimia, you have a normal or slightly overweight. And then for purging, and then for non-purging, it is a normal weight or slightly overweight. And the binging eating disorder is typically obese, all right? So they all have the fear of weight gain with the exception of the binge eating disorder. The body image is totally distorted in all of those. And with binge eating, it may be unhappy with the body and the weight. Binge eating can occur with, like we said, anorexia or binging, or their bulimia or non-purging bulimia. And then they use the use of non-purging methods to avoid gaining weight occur with all of them except for binge eating. And the feeling of lack of control over eating happens at different times with the different disorders. Some onsets occur. Anorexia occurs between 16 and 20-year-olds. Bulimia occurs most likely in women ages 21 to 24. Binge eating disorders is most likely to develop in 30 to 50-year-olds. And there are 3 females for every male with an eating disorder. And gay and bisexual men have higher rates than heterosexual men. In the lifetime prevalence of binge eating disorder is around 3.5% for women and 2% for men. For binge eating disorder, it is, obese people, it's 6.5 to 8%. The US lifetime prevalence for anorexia nervosa is around 0.9% in women and 0.3% in men. And the US lifetime prevalence of bulimia is around 1.5% in women and 0.5% in men. So what happens with medical complications for eating disorders? Anorexia can lead to death from heart arrhythmia, kidney damage, and renal failure. And bulimia can lead to electrolyte imbalance, low potassium, and a damage to heart, hands, throat, and teeth. Many times suicide risk is high amongst the anorexics, and long-term prognosis for bulimia is relatively good compared to anorexia, and there's high rates of clinical remission for binge eating disorders. Anorexia after 21, 51% fully recover, 21% partially recover, 10% do not recover at all, and 16 are no longer alive. For bulimia, the 70% is in remission after 11 to 12 years, and binge eating, 60% is in remission after 6 years. Okay, so people with eating disorders often later develop other eating disorders. So that's bidirectional transition between two subtypes of anorexia. A shift can go from anorexia to bulimia. There's few transitions from bulimia to anorexia. There's no shift from restricting anorexia to bulimia, and there's no shift from binge eating to anorexia or vice versa. Other factors that are important about the disorders. Eating disorders are becoming a problem worldwide. The attitude leads to eating disorders that are more common in whites and Asians than in African Americans, and some clinical features may vary according to culture. Risk and causal factors in eating disorders. They're multi-determined. There are biological, social, cultural, family influences, and individual risk factors that lead to eating disorders. With the biological factors, you're talking about hereditary tendencies, brain abnormalities, set point theory, and serotonin that lead to it. The socio-cultural factors, media-related, idealized extreme thinness, female internalizing ideal, and Western values towards thinness. What are some family influences for anorexia nervosa? Usually gender, age, sexual orientation, internalizing of thin idealization, perfectionism, negative body image, dieting, negative emotional and childhood sexual abuse. Treatments are very challenging and it requires hospital commitment. Some common treatments are emergency procedures to restore weight, antidepressants or other medications, family therapy, and cognitive behavioral therapy. Treatments for bulimia, antidepressants or other medications, and cognitive behavioral therapy. Treatments for binge eating disorder, medication, antidepressants, appetite suppressants, interpersonal psychotherapy, cognitive behavioral interpersonal therapy. So about 1.9 billion adults are overweight and 6 million are obese. With obesity, we have medical issues such as high cholesterol, hypertension, heart disease, arthritis, diabetes, cancer. The demographic factors are sex, race, ethnicity, and socioeconomic status. Body mass is what defines whether someone is obese or not. So the body mass under 18% is underweight. Normal is 18.5 to 24.9%. Overweight is 25 to 29, and obese is any BMI, body mass index, that is above 30%. And then 40, above BMI above 40 or being more than 100 pounds overweight is morbid obese, okay? So overweight and obese overall is 65%, 68%. Non-Hispanic whites, 67%, Hispanics, 77%, non-Hispanics, 38%, and non-Blacks, 76%. And this was in 2017. So the weight stigmas are based on negative weight-based stereotypes, juror bias against women and obesity, and healthcare professionals that blame patients who are obese. Some risk and causal factors of obesity: genetic inheritance, hormones, sociocultural influences, family influences, stress, and comfort foods. All right. Next, talking about chapters 12, neurodevelopmental disorders. So the DSM talks about these neural disorders, that the psychological disorders among children and adolescents mostly begin, they're very vulnerable as young children. They don't have as complex and realistic views of themselves or the world as they will have later. They have immediate threats that seem disproportionately more important, and they have a lack of experience that makes manageable problems seem insurmountable, and they're more dependent on other people. Early diagnosis is important. The DSM includes only 2 childhood disorders, and recent systems pay more attention to developmental factors in creating and using diagnosis for children. So anxiety and depression in children and adolescents often are comorbid with other disorders, and they're most common mental disorders among children and adolescents, and there's a higher rate amongst girls. Separation anxiety, which is defined as excessive anxiety about separation from major attachment figures such as mothers and from familiar home surroundings. The anxiety disorder is characterized with unrealistic fears, over sensitivity, self-consciousness, nightmares, and chronic anxiety. They have causes and treatments, and then a pattern of early family relationships, and then psychopharmacology treatments and behavioral therapy. And that's usually the cycle that we have for helping that. Childhood depression and bipolar disorder. Depression occurs with high frequency. Depressed moods can be replaced by irritability. Bipolar disorder is extreme mood swings and aggressive, irritable behavior, and it has been increasingly diagnosed in children and adolescents. This is because of biological learning factors, medication plus psychotherapy, exposure to trauma, and parental negative emotions. Some treatments for these 2 disorders, depression and bipolar: antidepressant medications, supportive emotional environments, and cognitive behavioral therapy. So disruptive impulse control and conduct disorder. These are externalizing disorders such as oppositional defiance disorder and conduct disorder. With oppositional defiance disorder, it is a recurring pattern of negative, defiant, disobedient, and hostile behavior toward authority figures that persists for at least 6 months. There are 3 subtypes: angry, irritability, mood, argumentative, defiant behavior, and vindictiveness. The risks include family discord, socioeconomic disadvantage, and parental anti-social behavior. Conduct disorder is persistent and repetitive violation of rules and disregard for the rights of others. Its variability is in a clinical presentation, and comorbidity exists also with other disorders such as substance abuse. Oppositional defiance and conduct disorder, there are possible causes: biological, personal pathology, family patterns, and peer relationships. With oppositional defiance disorder and conduct disorder, some effective treatments have been cohesive family models of behavioral techniques, and some ineffective treatments are punitive treatments. Elimination disorder, that's uresis and encopresis, and that is a single outstanding symptom rather than a pervasive maladaptive pattern. Enuresis is bedwetting that is not organically caused. Its variation causes faulty learning, immaturity, disturbed family, and stress, and the treatment is conditioning procedures and drugs. Encopresis is the inappropriate toileting for bowel movements after age 4. It's often comorbid with enuresis. It's more common in boys, and treatment is a combination of medical and psychological aspects. So these neurological, developmental disorders are a group of conditions that are characterized by early onsets and persistent courses that are believed to be the result of disruptions to the normal brain development. They can be onset during childhood, and then they can persist into adulthood. Attention deficit disorder, this is a persistent pattern of difficulties sustaining attention and/or impulsivity and excessive or exaggerated motor activity. Some characteristics is impulsivity, overactive behavior that interferes with the ability to accomplish tasks. A lower IQ is a possibility. Social impairment, and there is a high rate in boys. Some causal factors is number 1, hereditary. Usually it is 90% hereditary. Social environmental events and smaller brain size, slower brain development. And when we're talking about slower brain development, we're not talking about intellect. Usually that with attention deficit, it's in a different section. And in that different section, it is possible that the brain is just not moving as quickly. The neurons aren't firing as fast as they should be as fast as they should be. When we talk about the slower, there is a small percentage of students with attention deficit disorder that do also have cognitive delays, and that is more like at the 30% range, because usually we find that attention deficit disorder students are 70% gifted, and most of them, 70% of them, are gifted and talented. Some treatments for attention deficit and hyperactivity: medications, behavioral therapy, and family therapy. I would like to also give you the video on Dr. Amen, Healing ADHD. That is an excellent video. If you can find that on YouTube. He goes over 8 different characteristics or different types of ADHD that he feels are impacting different parts of the brain. And with some of them, medication is a must. And with others, you need to have the right medication. You need to make sure that you're looking at how much activity or how little activity is occurring in the brain in order to come to the right conclusion about which medication to put the student on. An example of that is if a student has what he considers a ring of fire where the entire brain is overactive, and then you provide a stimulant for that, it makes the child worse. If you If it is just overactive in one area of the brain, then a stimulant might be successful in treating. Autism spectrum disorder, it is a wide range of problematic behaviors. It has social deficits. It can have absence of speech, self-stimulation, repetitive movement, preoccupation with maintaining sameness. The causal factors is still unknown to this day. There are genetic risks, and it could be hereditary. Treatments is behavioral treatments and not normalizing through the treatments. There's new instructional and behavior modification techniques that reduce some of the symptoms. With autism, we have seen that by placing them amongst students that have more verbal abilities and putting them around more normal students, they tend to move towards normalcy, and then they tend to mimic those behaviors. They may still have some signs of it, but it seems to decrease over time as the students are exposed to the general ed population and what we consider to be normal. So those are the important factors for the chapters that you're reading during week 6. I'd like to talk about your assignments that are due this week 6. Week 6, you have 1 assignment and 2 discussion boards. Your 1 assignment is the case study paper. This is where you're looking for a character, either in a movie, a book, a movie, a book, anything, a TV series, and you want the character to exhibit some forms of psychopathology. So usually one of these different disorders that we've been studying throughout the book. And in a 3 to 4 page paper, you're going to include a brief identifying description of the character or a younger version of this character if the character is an adult. A description of the symptoms, the behavioral tendencies, the level of functioning, the ways of relating to others, and the management of those impulses and affects of that particular disorder. Using only one theoretical framework, you're going to describe controlling fears, beliefs and expectations, defense mechanisms, objection, relation, and then you're also going to include in that 3 to 4 page paper a description of how you would intervene with this person. So intervening is a key component of completing the assignment, because I also want to see how you would handle that particular student. An example of a character, and there's kind of lots of different movies out there. One movie that has some movies that have characters that have ADHD are Just Keep Swimming, Sound of Music, that's an old one, How to Train Your Dragon, Finding Nemo, there was a character in that also had ADHD. Percy Jackson and the Olympians had ADHD. Mrs. Doubtfire, so you kind of want to take a look at some books and different things on autism, oppositional defiance, any kind of thing, movie or book that had those characters that showed that. How I came up with that, I Googled ADHD, I put in a disorder, I said movies with characters, and then I put that in, and then I was able to come up with something. I've seen quite a few of those, the ones with ADHD, so I know exactly the characters that exhibited those signs, all right? So that's how you would go about looking for your character, or reviewing a book that you recently read that also may have had that. All right, thank you so much, and enjoy your week.